Kirill asked me to make this lecture regarding the AVM treatment by the venous approach, and I would like to focus on the difference between the porcelain vein and the pressure cooker, because there are several techniques which allow us to go through the vein, to occlude the AVM and whatever. And there is a lot of confusion between pressure cooker and porcelain vein, and I would like to clarify the situation. So as I did recently in Val d'Isère meeting. So clearly porcelain, we know that Limoges is very well known for the porcelain manufacturing, but this is not a question of marketing that we are speaking about the porcelain vein. So let's make the difference between both. Once you go inside the vessel with the microcatheter and you inject the liquid agent, so like the non-adhesive liquid agent like onyx or squid, so the first thing that the liquid will make is to layer on the wall of the vessel. It's exactly like how we manufacture the porcelain. So it goes on the wall of the vessel and it will fill progressively the vessel, but the vessel is not occluded during the procedure. So the principle is like this. So we put coils or we don't put coils. It's not a big deal. As you know, the coils will not occlude a vein, which is draining an AVM. And afterward, with the distal microcatheter, we inject the liquid agent, but the liquid agent as well doesn't occlude the vein. And like this, we have enough time to occlude retrogradely the nidus by the vein. So we use what we call the resistance law. So we higher the resistance by reducing the size of the nidus, and progressively we inject the liquid. So what's the difference between the porcelain vein and the pressure cooker technique? The porcelain vein, we said we go, so even if the technique is similar, but so the aim and the progression inside the nidus is not the same. So once we put the coils in the porcelain vein technique, the coils will not occlude the vein, which is arterialized. And after what, we have all our time to inject the liquid agent inside the nidus and going to the artery in a smooth manner. When we go in the pressure cooker technique, we put coils, but in addition, we put inside the coils glue, and by glue, we occlude the vein. But once we occlude the vein, we have to inject very quickly our liquid agent, and by injecting very quickly the liquid agent, we can get an occlusion of a normal vessel, and so we will create what we call the arterial ischemia. And so in our experience, the arterial ischemia is much more frequent when we are treating an AVM by the venous approach than a venous ischemia. We don't have, so it's really very rare to get a venous ischemia, but an arterial ischemia is possible when we are going very quickly from the vein to the artery. So all the papers that we published in the literature regarding the venous approach were done according to this porcelain vein technique. So here is an example. So we have our microcatheter inside the vein. We are injecting the contrast medium. You can see the flow inside the vein with the microcatheter. And so once we start injecting the liquid agent, you can see that the liquid agent layers on the wall of the vessel, as I showed you previously, before going in the middle of the vessel and occluding the vessel. So the vessel will not be occluded. And during the procedure, you can keep this vein opened and you will not go very quickly. So this is an example. For example, you have this tectal AVM, you have the tectal vein, which is draining the AVM, and afterward it goes inside the lateral mesencephalic vein and the Vermian vein. So here we catheterize in the Vermian vein. So the same collector, we catheterize the Vermian vein. And on the left image, you can see that the vein is full of liquid agent. But if you look to the angiogram on the right side during the injection, you can see that the vein is still patent. It's not occluded. So it gives you time to occlude the nidus progressively and to exclude it from the circulation. So the porcelain vein could be done with coils or without coils. So when do we use the coils? We use the coils once we have a large draining vein. So once the vein is very large, we put some coils just to limit the reflux with our liquid agent. So without coils, Once the vein is really very tiny, you don't have to catheterize with 2 microcatheters and whatever, like in this nucleus accumbens AVM which bled. So you can see here the nidus, which is in the middle of the image. And so you can see the draining veins. So the anterior cerebral veins on the left side, the left basal vein, the left uncal vein, and after what you have the cavernous sinus and the IPS. So on the right side, you can see as well the right paracavernous sinus. So when you inject the left carotid artery, you can see the anterior cerebral vein from the contralateral side, etc., etc., etc. So clearly, so we have to understand this. We can understand it by using the 4D images and whatever. And even if you don't have the 4D images, you can make a CTA with a MIP reconstruction, and you can understand that. So you understand the feeder to the AVM, which is here, the Hübner artery feeder, and after what, so all the draining vein, and so you can see that the anterior the superior cresmal vein drained in both anterior cerebral veins. So here, the first step of the procedure is to go by the artery and the selective catheterization of the Hübner artery. This is a very important step in order to understand again the vein. And so here you can see, once you make a selective injection, you can understand the venous system. But the Hübner artery is a short artery. And so you cannot inject directly this AVM from the artery because you have a big risk to get a reflux in the anterior cerebral artery. So we decided to go by the vein here. So what do we have to do? So we put 2 balloons just to limit to create an aspiration on the Hübner artery, because as I said, so we have to occlude the artery backward in order to be sure that we occluded the AVM. And so we went by the system, so just to attempt the superior chiasmal vein. And like this, so we have here the superior chiasmal vein, both anterior cerebral veins, and etc. So after what, we injected our liquid agent, and so here you can observe that we occluded the artery backward thanks to the balloon, and in a let's say in a soft matter. So we don't have to inject quickly, and we don't have any risk to go inside the anterior cerebral arteries. That you can see here, the nidus is totally excluded, the AVM, the artery, and the vein as well. And here you can see the superior chiasmal vein. And despite the fact that we occluded here the anterior communicating vein, you can see on the MRI that we don't have any venous ischemia. So the venous ischemia is not the most, it's not our most concern, which is really our concern is the arterial ischemia. So here is another case. Let's say why, so we can make the porcelain vein without putting coils. So here you have a superior cerebellar AVM, which is drained by 2 different veins here. So you can see the precentral vein and the lateral mesencephalic vein. So you have to go in each of them if you want to cure the AVM. Why? Because so they are differently draining the nidus. So here we have to go inside both veins. We will not put catheters to put coils and whatever, no need for that. So we occlude both veins and nidus. And after what, this is the control. And on the MRI, you can see that we don't have any venous ischemia here. So clearly, the porcelain vein technique is a safe technique, which allows us to occlude the nidus without occluding the vein at the beginning. And so it doesn't oblige us to hurry when we are treating the AVM, and it avoids the arterial ischemia. So sometimes, so now always we use the balloon. Why the balloon? It's not only to reduce the blood pressure at the level of the nidus, but so the balloon is so to create an aspiration in the artery in order to bring the liquid agent when we are injecting. So excuse me, I will come back to the animation. So we inject the liquid agent, and so we want to go inside the feeder to the AVM, but we don't have to go inside the normal branches that you are seeing here. And I will give you a demonstration of that. So the goal is to occlude the artery, the nidus, and the vein. Let's see this case. So this is a demonstration of that. You have this nidus in a young boy. So we went inside the vein to the nidus. We put some liquid coils, and the balloon, you can see it downside. So the balloon is inflated here, so to create the aspiration, and our goal is to occlude the feeder without occluding the normal vessels which are close to here. So this is our goal. So here you can see the progression inside, and very slowly you can see the injection of the feeder without going backward to the normal branches. So this is our goal, to feed the feeder to the AVM retrogradely from the vein, but without going to the normal branches. And so now the machines and the protocols on the Siemens machine, it allows us to propose the cast of onyx or a squid with the angiogram, the initial angiogram, and get this result, which is a total occlusion. And here again, you can see that we don't have any arterial or venous ischemia. So I would like to analyze these things. What is dangerous when we are going to the vein, so to the AVM by the venous approach? It's we look to all the factors which are a risk factor for the bleeding during or after the venous approach. We look to the nidus location, the nidus size, the cortical draining vein, the deep draining veins, and whatever. And so we found only one factor, risk factor, is the nidus size. Clearly, the nidus size is really very, very important. So once you have, we had a cutoff which is around 2.7 centimeters. So if the nidus is still bigger will be the nidus, and higher will be the risk of bleeding of the AVM during and after the treatment using the venous approach. So this factor is really very, very important. So this is why once we want to go by the venous approach, we have first to reduce as possible as we can the nidus before going to the venous approach. So now I understand some people who say that the AVM treatment is a safe treatment. We have less than 5% of risk during the procedure. It's not true at all, because whatever is the technique, you are going by the vein, you are going by the artery, you are making radiotherapy, you are making surgery. So we have, in more than 60% of the cases, this kind of halo which is surrounding the nidus after the procedure. And if it's in a functional area, the patient will get a transient deficit, and sometimes he will not recover completely after that. This halo will disappear over three months, so the person could keep some deficit on that, so you have to take care about that. So in my conclusion, the AVM total exclusion is artery, nidus, and vein. The porcelain vein technique doesn't occlude the vein during the retrograde feeling of the nidus, contrarily to the pressure cooker technique when we put glue. It allows a progressive retrograde feeling of nidus and feeders. Venous ischemia is rare during this venous approach. Arterial control by balloon temporarily during the occlusion is recommended. So just to reduce first the flow, and second, to create this aspiration in order to obtain the retrograde feeling of the artery in a safe way. So this is all what I have to tell you, and thank you very much for your attention.